Kia ora, my name's Margie Olds, and this is the Glenohumeral Gurus podcast. This is a podcast for clinicians interested in shoulder rehabilitation. I'm a shoulder therapist based in Auckland, New Zealand, and in this podcast I interview clinicians and researchers across the globe about their research and their clinical practice on how we can improve outcomes for people with shoulder pathologies. The aim is to learn, laugh, and try to work out how we can help people with shoulder problems. Enjoy the podcast. This episode is brought to you by Flawless Motion, shoulder braces for people with shoulder instability in male, female, and bilateral versions. So check out flawlessmotion.com or now flawlessmotion.co.uk for your shoulder brace requirements. Right, on with the podcast. Hello, everybody. Welcome to Glenohumeral Gurus. Today is my great pleasure to welcome my friend and colleague, Dr. Angela Cadogan, to our wrap-up synopsis, summary, debrief session on frozen shoulder. Ange, welcome. So great to have you back on the podcast. And I really look forward to hearing your expertise. Do you want to just quickly introduce yourself? You've been on the podcast before around AC joint and sternoclavicular joint, and you co-hosted the session with me. Can you just maybe just introduce yourself to the audience?
Yeah, thanks very much, Margie. A pleasure to be back again. So I work as a specialist shoulder physiotherapist. I do consulting work in private practice in Christchurch. I work in the hospital and orthopedic triage role in the elective shoulder service, working with the orthopedic surgeons in there. And yeah, I've got a pretty special interest in frozen shoulder from a personal and a professional perspective. So yeah, looking forward to debriefing the great conversations that you've had with your guests over the last few weeks.
Yeah, they've been fantastic, haven't they? And I particularly reached out to you because I know you've been across all the research in that space, and we spoke to some really interesting people, didn't we, completing their PhDs in this space. And it's really exciting that they're across this and the growth that's happening in frozen shoulder right now. That was really exciting for me to learn.
Yeah, similar. I think yeah, the amount of work going on, I think, is huge. It's been a little bit put in the too hard basket, I think, for a
Mm.
number of years. So it's great to see now there's more people looking into it and coming up with some things that we can use with our patients.
Yeah, yeah. So my plan for today was to broadly speak around the pathoetiology of frozen shoulder and just define that for the audience to get them across all the updates in that space, and then to work through assessment, diagnosis, treatment, and of frozen shoulder and the broad under those broad categories, what we learnt from our speakers and what you know from other research. That was broadly my plan. So. That's it. Do you want to kick us off then with what you understand about the pathoetiology of frozen shoulder, the pathological stages of the condition?
Sure, yeah. Well, I think if we separate the two things out, we know quite a lot now about the pathology of frozen shoulder,
Mm.
a lot less still about the etiology of
Yeah.
frozen shoulder. And I mean, in an era where, we're from a bit of a space geek here, we're spending spacecraft to the edge of the universe, and we still don't really know that much about the etiology of frozen shoulder. It's still a bit of a mystery.
Mm.
But I guess in terms of the pathology, I think for me, one of the bigger understandings that I got in all my readings from frozen shoulder is that it starts off with a low grade inflammatory process. But the inflammatory process that we get in frozen shoulder is not the same as the acute inflammation response that we get after an injury. So, you sprain an ankle, you get an acute inflammatory response that then works through a series of stages. You get that fibroblast stage, but then that moves fairly quickly into the remodeling and the repair stage. So it kind of restores tissue structure. But what we find with the inflammation in frozen shoulder is that you start off with that low grade inflammatory response. You get into the fibroblastic stage, and that's where the pathology differs because that fibroblastic stage becomes proliferative, it is very dysregulated, and it doesn't end. And that's the
Mm,
difference, I think, from normal acute inflammatory response. So it becomes very dysregulated. I think, as Michelle pointed out in your podcast, you start to get differentiation of the
mhm,
fibroblasts into myofibroblasts. And the myofibroblasts, having the myo in the world means kind of muscle, I suppose. So that's
mhm,
why it starts to contract. And
mm.
then you just get this extreme thickening of the capsule, very disorganized, dense collagen, and it just doesn't have that repair and remodeling time course that you see in that acute inflammatory stage.
And we don't understand, if I'm correct, why there is that differentiation. We understand from a lot of the work that these guys have done around risk factors and predictive, but do we know why you get that myofibro? Why does that happen?
No, well, I think it seems to be, as we know, like you mentioned, there are a lot of risk factors. Metabolic seems to be the biggest
Mhm.
one, but there's also a number of hyperlipidemia, hormonal, endocrinologic, immunologic. So there's a combination of a lot of factors. But I
Mm.
think it's probably the low grade inflammatory response in a biologically primed individual. So I think, you get
Yeah, right.
someone who's got all the right settings there, unfortunately for them,
Mm.
whatever those might be, that actually tip the scales into this really dysregulated fibrotic process. And from there, well, we haven't found any good way to stop it. I think that's where it starts to work through, its stiff phase and then eventually into the thawing phase. But yeah, it just doesn't follow that normal time course like that typical acute
Mm.
inflammatory process does. The other thing too about the the early stage, so that low grade inflammatory process, is that it is angiogenetic, or if you like, or angiogenesis. So you are getting ingrowth of a lot of new capillaries and nerve endings into that
Mm.
synovium,
Yeah,
and that is probably one of the reasons why it is so painful, because of that neovascularity that you get in that
yeah.
early stage. And we do see that with other inflammatory conditions, so even osteoarthritis and tendinopathies. So you'll get
Hmm.
that similar sort of process, but it does seem to really affect that synovium of the glenohumeral joint with a vengeance.
Yeah.
And it can be very, very painful.
Yeah, I think something that was interesting that I learned is in terms of how making the diagnosis, how far we actually get through the stages, do you know, before you can really confirm that. Do you want to speak to the stages? Where are you at with painful and stiff, how you're freezing, thawing? Like, there's a number of different ways you can put this together, eh?
Mm.
Clinically, where are you at with that? What's important,
Yeah.
you think, for clinicians?
I think pathologically, there are definitely the three stages, and I still explain it to patients in that way. So you get that
Hmm.
early painful phase, which matches up with the inflammatory phase of the
Hmm.
pathology. Then you get that fibroblastic kind of proliferation and that capsular thickening. So then you start to get that stiff phase, and
Yes.
then eventually pain returns to zero. It's pain free, they're just stiff, and then you move into that thawing phase, and that's where the collagen starts to sort of reorganize itself, and you sort of see that switch from that very type 3 disorganized collagen back to the type 1 collagen. So pathologically, I think there are definitely three phases that
Hmm.
overlap. They're not distinct, but
Yeah.
pathologically that seems to be the case. But when it comes to treatment, that's when I kind of make that distinction between, is it pain predominant or stiffness predominant? And that tends to be what drives my
Yes,
decisions from a
okay.
treatment point of view.
So actually the classification, there's a three-stage from a pathological point of view, but a two-stage from a clinician treatment point of view. It's
Absolutely.
also interesting for patients to understand those three stages, eh? Just in terms of expectations and
Mm.
education around that. Is that what you think? That's what
Yeah,
you're doing.
absolutely. Yeah. And I think once you explain it to patients, I think particularly once they hear that there is an end in sight to this,
Yes.
then
Yes.
they really actually appreciate that explanation. And I have had so many frozen shoulder patients through the clinic now where I have not touched them, I have not given them an exercise, I've done nothing except just sit there and explain it to them.
Mm,
And this is often on the back of perhaps not having had a clear diagnosis, or because it's been in the early stage, it's not been possible to make a clear
mm-hmm,
diagnosis. But by the
mm-hmm.
time they get to me, it's stiff and it's relatively
Yes,
easy.
yes,
But the explanation alone, I mean, the quotes, it's almost identical. All the patients say, I feel so much better already. So you
yeah,
can see a weight almost physically lift off their shoulders once they understand it. So I think it is worthwhile definitely explaining it to them.
yes,
In terms of the treatment classification, stiff or painful, I don't probably go into so much depth about that, but that's certainly what
mm-hmm.
guides my clinical decision making. Um, and I think one of the other interesting things, and I think this is an area I'm really interested in, and I think this will probably help guide our treatment more so than a lot of things that we've had to date, if we can get more ground or evidence in this area. Something Michelle also talked about was really trying to identify that early stage, because as you said, by the time we make the diagnosis, it's already stiff. So we've
Yeah,
lost time and we've lost ground to some extent in treating that inflammatory phase with guideline-based treatment, which to date the best we've got is that intra-articular corticosteroid injection. But if we can start to see, I think Michelle mentioned about early ultrasound features of
yes,
frozen shoulder. So I think he
yes,
talked about the vascularity in the rotator interval, the thickening of that coracohumeral ligament,
yes,
the obliteration of that subcoracoid fat pad, and I think there was one other thing which just escapes my memory at the moment, sheath, biceps tendon sheath fluid. So I think
yes,
if we've got someone with a painful shoulder, if we're referring for an ultrasound scan, and we can perhaps, if we can get a lot of good solid evidence in this area, upskill the sonographers, add that to
mm,
the features that they look at when they perform an ultrasound scan, if we can start to identify some of those features sonographically,
yes.
because it's
That's a mouthful.
yeah, because it's very difficult clinically, then
Mm, maybe
perhaps,
that would help at early identification, therefore early intra-articular steroid or whatever we decide the treatment would be.
definitely
That
early
would
targeted
help
treatment,
us, eh?
for sure.
Mm. It's interesting, eh? I was reflecting on as I was listening back through these podcasts on the imaging, and I mean, previously you and I had talked about the role of X-ray, but I hadn't necessarily talked about the use of ultrasound in this space. Where really your take home, or you think the growth phase is around early identification through ultrasound, eh? You think that might,
Well, I think, yeah, certainly the diagnostic criteria. X-ray is still important because we need to make sure it's not osteoarthritis or other things that
yeah,
can cause a stiff shoulder. Um, but by the time you X-ray, the X-ray is not going to give you any other information other than
yeah,
excluding a whole lot of stuff. It's not going to
yeah,
tell you what it is. It will tell you a lot about what it's not.
yes,
So I think if we can get any early indicators from ultrasound, which is probably the most accessible and least risky procedure,
yes,
that would certainly be helpful, because we do know that earlier, like if it's an inflammatory condition, which then starts to flip into a proliferative fibrotic phase, the
yeah.
earlier we can get into that inflammation and treat that inflammation, potentially the less fibrotic and stiff it might come, down the
The
track.
less the impact on the patient in terms. So really the argument is for early identification, and maybe the ultrasound is useful in that phase, and the X-ray, by the time you're stiff, you're looking to rule out a number of other factors with the X-ray. You would.
Mm, that's
Something
right.
that sort of confused me a little bit, and I'm interested to hear your thoughts, was around our classification system of primary and secondary frozen shoulder, and whether that's a useful framework for us to keep using or not. And I guess this depends on your healthcare system, doesn't it? In terms of it's a response to some sort of minor traumatic injury, or is related more to your metabolic factors. Where are you at with that currently, right now, mid
Yeah.
2026?
That's right. Yeah. Well, I mean, it's been written up for decades, really, about the primary
Mm,
and secondary classification of frozen shoulder. But to me, clinically, once they've developed a frozen shoulder, the treatment is the same. And I'm not aware of any literature or evidence that suggests that we
Mm,
should treat them differently. So I think probably that if you're looking at one of the categories of secondary frozen shoulder where it can be associated with concurrent shoulder pathology, whether it's rotator cuff or,
yeah.
small, even in fact, paradoxically, the smaller rotator cuff tears seem to be more prone to developing a secondary capsulitis than the
Mm,
larger ones.
mm,
Calcific tendinopathy can also create an irritant in that glenohumeral joint. So I think probably clinically, when you know there is concurrent pathology, you come down to a decision about what do you treat. Are you treating the pathology, the rotator cuff tear or the calcific
mm.
tendinopathy, or are you treating the capsulitis? And in my experience, the capsulitis, the frozen shoulder, trumps whatever the background pathology is because that becomes the more dominant feature clinically, symptomatically, and that is the one that you treat. Once that's resolved, you can come back and look at the other pathologies if they're still symptomatic and relevant. But other than that, I don't treat them any differently, and I'm not aware of
Yeah.
any literature that suggests that they behave any differently in terms of time course or anything else.
Mm,
So again,
mm.
it comes back
Okay.
probably to that, certain individuals are more susceptible based on a myriad of factors,
Yeah.
especially metabolic factors.
The caveat to that, and always the difficult patients that I end up navigating are those, say, post-cuff repair, who then develop the frozen shoulder. Now, I can see you smiling. You're obviously navigating the same patients because we need a certain amount of healing there for the cuff repair. And but if you develop a capsulitis, then we need not the healing, not the inflammatory process in this part, but the inflammatory process in the other part. What's your advice here? Because I've typically, I mean, I've steered away. I don't advocate for steroid injection in this population, and I look to protect the cuff and step people through and liaise with the surgeon around when they think might be an appropriate time. What are that's what I've been doing. I'm sure you have some clinical nuggets for people here. They're
Mhm.
difficult to manage, eh?
They are difficult to manage, and my approach is exactly the same as yours. I think the difficulty is in a post-op patient is knowing where is that transition between just a painful post-op shoulder into which is stiff,
Mm,
expectedly stiff,
mm,
into a capsulitis or frozen shoulder presentation. And I think particularly in that rotator cuff tear population, for me, the tipping point is when, if we look at typical trajectory of recovery, it should be if not every week, at least every fortnight, pain levels should be gradually reducing, and you
yeah.
should be seeing small improvements in range of motion. So if that pattern stops and you start to see either a plateau or an increase in pain and irritability and perhaps a leveling off or a worsening of their range of motion, to me, that's the flag that says this may be more moving into a capsulitis. And from that point, my management is exactly as you've described. We
Mm,
don't want corticosteroid around a rotator cuff repair in the early stages because that will impair healing.
mm,
Um, the thing I do tell my patients, and there's good evidence around this as well, is that this may slow down their recovery, but at the end of their rotator
mm.
cuff repair outcome, it is not going to do them any harm. And in some respects, there is some evidence that says the stiffer patients early on may be slightly more protected from re-tears later on.
Yeah,
So
I
the
remember
stiffness
that
is
study.
not a
Yeah.
problem in their long-term outcome.
Yeah, and I think there were some interesting points both for Michelle and Pablo around not the guarding of movement and trying to work out what is guarding and what is actual stiffness. And I guess that's where Pablo's work was really interesting in that space, as he went after muscle guarding. And I think the negative finding of no difference in muscle thickness and that, that is almost as valuable, eh? Tell me, what are your thoughts around muscle guard? Because Michelle was talking about encouraging people to move, and Pablo was around, well, don't assess the range of movement on the first session almost, try to get them moving and get them back to see if the range of movements is the same. What are your thoughts around guarding and pain and how people are protective? What do you think there?
Yeah. I think muscle guarding is definitely a feature. I would say, and probably most patients I see with frozen shoulder to a
Yeah.
greater or lesser extent. And some patients, it is driven by pain. They just
Mhm.
know if they move it, it's going to hurt. So it's sort of a
Yeah.
protective, almost a protective muscle guarding, muscle spasm response.
Mhm.
Some patients, it's fear, like they just
Yeah.
do not want to move it because the pain is so severe. There must be something really wrong with my shoulder. So they
Yeah.
just don't want to move it. So I think there are all probably almost subtypes of muscle guarding and
Mm.
different reasons why people are guarded. And the interesting thing I found too, with my frozen shoulder was that getting in water was actually really interesting. Now, I got in,
Okay.
as soon as I got into a pool, I felt like my movement improved, not
Yeah, right.
dramatically, but a bit, like I
Yes.
felt like there was a little bit more movement in the water. Now, whether that was just,
Define that. What does that mean in the water? You're in a pool, you're on
yeah,
holiday swimming, or you've
yeah, just we were in, well, Fiji last winter and in a pool. So it
it
was
needs
nice
to be
and,
warm, you think, or does it matter?
well, the pool wasn't particularly warm, I have to say, but so
Temperature
whether it
is
was the warm weather, but definitely getting in the pool, trying to do, the stiff movements, the abduction, the flexion, did seem to improve a little bit. We're not talking dramatic, normal range of motion, but I just think we know that the water does have quite a good effect, a relaxation effect on muscle spasm,
yeah,
and that was just an example to me that said, yeah, actually, maybe some of this may be an element of guarding, but it
yeah.
certainly didn't change that capsular pattern.
I think what's interesting there too, I think about, open chain versus closed chain exercises and how comforting and reassuring it is to have your hand touching something. Do you know? So typically would put people on their hands and knees or on the table and do range of movement sort of that way where you're not worried about where your hand's going to be. And it seems maybe the patterning is different or the muscle recruitment is different or something changes in that way. And that's been my experience with people.
Absolutely.
You've got
Yeah.
better control as a patient in terms of your positioning. Uh,
Definitely. Yeah. And that may go to some of the work that your speakers talked about with some of that central pain processing and central
hmm
factors feeding into
hmm
that. I think the other thing, one of them mentioned, I can't remember which one, about the group of patients who have an intra-articular anesthetic and corticosteroid injection for frozen shoulder and immediately have significant improvement in their range of
Yes,
motion.
yes.
So, I mean, I've watched a lot of glenohumeral joint corticosteroid injections, and I would say, in my experience, it's probably less than 10% of patients have that reaction, but some
hmm
of them definitely do. So the question is then, is it really capsulitis or is it more the muscle guarding than the
Mm.
capsulitis that's sort of resulting in that limitation? Um, is
And
it an active limitation versus a passive limitation? So it does
yeah,
happen, and you do have to then question the diagnosis. Are you treating the right thing? If that really
yeah,
results in almost near normal range of motion immediately, which would not happen if it was a frozen shoulder,
no.
um, or is it just still a bit of capsulitis with some guarding going on there as
Where
well?
do you think the research is going to, I know we're going to talk about this later, but I'm interested in this muscle guarding because what we found from Pablo is there's no difference. So there's no difference in muscle length or muscle thickness. Where do you think, how are we going to find who's a muscle guarder and who's not? What sort of research needs to happen? That was my question after, okay, so you've got a negative finding. How are we going to find a positive? Like, what are your thoughts
Mm.
there?
Yeah, I don't know. I think the good thing we can take from his work is that a lot of it is then not around structural changes in the muscle. So it must be
Yeah.
some sort of reflex, arthrogenic, some kind
Yes.
of central mechanism, a bit like I think, the what we see in the knee extensors
Yes.
and other muscles around the body. So I think that if we're doing that sort of research, I don't know whether I don't even know how they measure those things. It's not my area,
Mm.
but talk to
No,
the people that measure reflex muscle contraction and see
and
perhaps where that
see
goes.
what the space is there.
Yeah.
Okay. So let's move into assessment then around frozen shoulder. What were your takeaways and what do you think is important for clinicians in the assessment space?
Yeah. Well, I think aside from the physical assessment, so obviously the passive range of motion is the key feature. Sorry, I've
Yeah.
just but I think all of your guests actually also highlighted that there are almost sort of subgroups of patients. So if they, of all of the predictors that they looked at, so they looked at a number of metabolic factors, mechanical factors like range of motion. They looked at central pain processing, so pain pressure thresholds.
Yes.
They looked at trait anxiety and yeah, a range of things. So all of them came out, or many of them did come out as associated with pain and disability in frozen shoulder.
Yeah.
None of them, if what I understand from what they were saying, if I understand correctly, none of them was strongly predictive. So none
Mm.
of them really explained a huge amount of the variance in outcomes. So we know there's a lot of factors associated, not necessarily predictive, but what that does tell us is perhaps there are phenotypes within frozen shoulder that maybe we should be looking a little bit more broadly in the patients that we see with frozen shoulder. Things like the metabolic screening, we're already looking at range of motion.
Yeah.
Should we be looking at screening more psychosocial factors, looking at pain processing? And I think it was Pablo talked about the pain processing and the trait anxiety.
Yeah. Fabrizio was as
Oh,
yeah.
right, Fabrizio,
Yeah.
yes, versus the state anxiety.
Yes.
And
Yes.
it is interesting that it does parallel our colleague Jackie Clark, Dr. Jackie Clark, who's a
Yes.
pain specialist who's done quite a lot of work in this area. And she did find similarly that trait anxiety, pain sensitivity, so generalized sensitivity to pain,
Mhm.
and low registration. So that's people who don't automatically register nociceptive input or it's delayed
Okay.
registration. So, in other words, they can do a lot more before they register it's sore. Therefore, they become very irritated before they
Yeah.
learn to
Okay.
stop. So,
Yeah.
those were all associated with persistent pain. And that was more in back pain. But it's interesting to see a similar theme with that trait anxiety starting to come out
Mm.
in
Mm.
frozen shoulder as well. So, perhaps we should be looking at the psychosocial. So, the fear, catastrophization,
Yeah.
monitoring it with outcome
Phobia,
measures.
really. So I
Yeah,
guess there's if clinicians are thinking about assessing a patient with frozen shoulder, there's these three different buckets, aren't there? Do you know?
yeah,
So there is these the risk factors around the metabolic disorders, things that provide then that low grade inflammation. So the thyroid conditions, cardiovascular, the metabolic, the diabetes, those sorts of things. And there's obviously then a physical component, isn't it? You need to measure both active and passive range. Your thoughts, and then the final factor around the psychosocial factors and measuring catastrophization, anxiety, whether it's state or trait, the kinesiophobia, those kind of factors. And so your assessment should broadly cover those categories, shouldn't it?
I think so. Also, the pain processing as well, and looking at um, some of them do become centrally sensitized as well. So I think,
Yes.
and that would obviously be treated differently. So
Yeah.
yeah, I think, and it sounds a lot to assess, and it is a lot to assess, and you wouldn't necessarily do it all in one session, but I think you'll get a feel for people who are really struggling. I think the higher level of distress probably and disability, probably the more important it is, I think, to really be more thorough in the screening for a lot of those factors.
Yes.
I think, especially around the central pain, because there are medications that may also assist with that.
That make
But
a difference.
also, there is that sort of neurogenic pain or neuropathic pain phenotype as well from that
Mhm.
neovascularization and irritation
Mhm.
of neural structures. So it leads to potentially there being other medications other than anti-inflammatories or
Yeah.
corticosteroids that may also be
Yeah.
useful. So I think
That
that
may make.
does
Yeah.
need more of a broad brush approach, I think, for patients who are more distressed and more disabled, I think.
Hmm. So as I was reeling that off, it occurred to me that in the physical assessment, while you might look for active and passive range, the role of resisted testing in a cohort that often then have accompanying bursitis with their limitation in capsular range. What does that mean? So like the textbooks would say you need to, it's not a, in Pablo's work would say the muscles aren't involved, therefore resisted testing should be pain free. And clinically that's not always the case, is it? What's your what's your advice around that?
Absolutely, yeah. Well, I think if you look at the anatomy of the rotator cuff, particularly the insertions of the rotator cuff, they are intimately blended with the capsule.
Hmm.
So I think, yes, you can get bursal inflammation along with the capsulitis and the
Yes.
synovial inflammation, but because the rotator cuff is intimately blended with
Yes.
that capsule, anything that stresses that capsule, i.e., a resisted rotator cuff test, could potentially cause pain. And that's where I think, but maybe in the early phases, that's where maybe the misdiagnosis sometimes happens as people do a resisted rotator cuff test and it's painful and they
Yeah.
think it's a rotator cuff problem and they pursue that path. And it is very difficult to differentiate when it's not stiff. But I think that is the mechanism that I
By
see
which it's
definitely.
painful.
Yeah.
Yeah, that's really good advice. In terms of the coracoacromial ligament test, that was a new one on me. Tell me what's your thoughts around that? You've been using that clinically?
Only more recently, yeah. And I think it's not evidence for that's recent, I think, in my
Yes.
from what I
And
can
evolving,
recall.
maybe we should say.
Yes, and evolving definitely, but yeah, the coracohumeral ligament is definitely one of the most affected structures in frozen shoulder. So if you palpate its insertion and it's painful, you could argue it's a fairly non-specific finding, but
Yes.
um, I'd be interested actually to look that up and look at the sensitivity because I imagine the sensitivity may be higher and relatively good in that sense.
Yeah.
Um, yeah, so I guess the rationale is you're pressing something that's inflamed, and if it's painful, then that can help also
Yeah.
with your diagnosis. Obviously, you
Yeah.
wouldn't make a diagnosis on that alone. It's another one in the
In the
weight of
box.
evidence that you're collecting through your clinical examination. But yeah, certainly I'd put more emphasis on that range of motion and that global loss of
Yes,
passive range.
because in the context of a patient that may be highly sensitized, it hurts when I touch you is not necessarily a good indicator.
Correct.
Yes.
Yes.
Let's talk about then. So, anything else you've got in that diagnosis assessment phase there you think is important that clinicians, we've got those three buckets broadly. We've like drilled into the physical component of that. Making that diagnosis is really only when you start to lose your range, but maybe there's some indicators for that that might help us early on, that might direct treatment early on. Is there anything else
Yeah, I
you
think
wanted
that's
to add in that space?
no, that's definitely a fair summary, I think.
Yeah. So then I was really interested, and I guess this is what sort of started this whole journey, was a systematic review from Michelle on exercise and how that the role of exercise in frozen shoulder. What are your thoughts there? What do you think?
Yeah, absolutely. Well, again, I think it comes to the different phases, like the classification for
Yeah.
treatment purposes of painful versus stiff. So, absolutely, in the painful phase, I would go so far as to say exercise is any exercise to end range. And when you look at how stiff some people are, that's not very far,
Yeah.
would be contraindicated because we know it's an inflammatory response.
Yeah.
We know the fibroblasts differentiate to myofibroblasts and they are tension sensitive. So as soon
Hmm.
as you stretch a fibroblast, that's going to signal it to convert to a myofibroblast, which is then going to contract even further. So while
Yeah.
some people do try and stretch and exercise in that early phase because they see themselves losing range of motion, ultimately that might result in them becoming stiffer later on. So I think
Hmm.
exercise in terms of stretching, but even exercise in terms of resisted test or resisted exercise for the reasons that I explained before, because of those capsular connections,
Mm.
again, irritating that capsule would be. something I would avoid in that
Yes.
early painful phase.
Yes.
Um, Later on, in that stiffness predominant phase, or certainly when pain levels are much lower, lower irritability, that's when exercise has more of a role. But I think, as Michelle pointed out, I mean, what is exercise in terms of research evidence? But
Yeah.
also, if even if we're talking about stretching, what capacity do we really have to stretch a 6 millimeter thick capsule with,
Mm,
I think it's very,
mm,
very difficult to do that. And it would take an enormous amount of force applied over a very prolonged period of time to really make much of a difference.
mm.
So I think it does have a role. I was interested actually, I haven't looked this up recently, but I know a few years ago there was some anecdotal evidence coming out about the use of eccentric
Yeah.
exercise and stretching, say
Yeah.
eccentric external rotation at the very end stage. So this is very
Mm.
stiff, no pain, and you can load it fairly heavily. And it was pretty anecdotal at the time. It had reasonable rationale behind it because we do know that especially in the metabolic dominant frozen shoulders, you do get much stronger cross links. So you get the AGEs, which are almost like sugar links. They almost caramelize the
Mm.
cross links, and so they're very difficult to break. So the theory then was if you're using eccentric loading, that might help to sort of break these cross links and improve range of
Yeah.
motion. So I haven't seen anything more recently come out about that, but I guess if anyone listening has got any information,
Yeah,
I'd
then
be really pleased
get
to hear
in
it.
touch. We can add that in the show notes. I wonder also if it's about that passive relaxation and the lack of guarding in those new ranges. Because I hear you. It's not like me lying on the floor stretching is going to like break up some of these crosslinks. But maybe there's a role then in maybe the relaxation component. It'll be interesting to see what that looks like. And so then, as I was listening back through these podcasts, found myself saying that I very rarely use strengthening in this cohort. And then I had a patient, obviously, who presented with a 2 year history of frozen shoulder that hasn't then been using her arm with some disuse atrophy, is what I thought. And so then I found myself applying some strengthening exercises as some sort of, I don't know, is that karma? I don't know. Do you have any thoughts there? Because we had said, oh no, I don't typically strengthen.
Other than podcast karma, yeah.
Podcast karma. Who knew that was a thing?
I know.
Hashtag podcast karma. So,
Exactly. I must say, I mean, I would have said the same thing. I can't think of a frozen shoulder patient where I have really given them a strengthening program. What I tend to find with them is that as soon as the range of motion starts to return, they just start using their arm again and
yeah.
they become functional. Like they're rearing to go. They might be a little bit weak because of the duration of stiffness, but as soon as that stiffness eases up, they just seem to start using their arm. And I guess it's typically an age group. We're not talking usually about young elite athletes or,
No, and
people
this
in.
was a high functioning woman in her 60s who was wanting to do some quite, advanced and activities and she was weak in that space. And after
Mm.
I'd given her the stretching, then she came back and then I was like, oh, actually. So it's always good to assess, isn't it?
Yeah,
We
absolutely. So I
assess.
think if the functional goals are such that they need good strength, especially in elevation, in that age group where also they're at risk of rotator cuff tears, especially if they've
Yes.
had a history of disuse, then I think there is definitely an argument for that. So it's probably
Yeah.
more just assess the patient in front of you, really.
Yeah, exactly. Exactly. Don't always, or you'll get caught with podcast karma.
Yeah, that's the one.
Where do you think we're going, eh? Where to next from all, I mean, there's some really exciting stuff happening in this space, which is really nice. And some of it we can continue as we were, and some of it we should have another look at the patient in front of us and see where we are. Where to next in this frozen shoulder space?
Yeah, well, I think that probably the holy grail for frozen shoulder is looking at that inflammatory process, tips into that dysregulated fibrosis.
Mm,
Why is that, and what can we do to disrupt that and kind
yeah.
of get that inflammation to work through its natural course a lot quicker? I think that is going to be where we're going to make the biggest difference for people with
Yeah.
frozen shoulder. If we can arrest that process earlier on, perhaps we'll reduce pain earlier, it won't get as stiff, they won't have that prolonged period of disability with a very stiff shoulder. There is some work that has been going on for a few years in this space around
Mm.
medications. They have been looking at a number of medications that do target that pathology. So they're looking at anti-fibrotic drugs, and these are still
Ah,
in rat trials, so they're not even a human
yeah,
trial stage
okay.
yet, very preclinical. But in rats, administering anti-fibrotic drugs, so similar to what they use in patients with pulmonary fibrosis and other fibrotic disorders, they
Yeah.
have found that it did actually reduce the capsular thickness and improved range of motion.
Mm.
So, um, also it sort of fringes a little bit into some of the cancer drugs as well. So the anti-growth factor drugs, and the growth factors
Yes.
is what creates a lot of that capsular thickness.
Yes.
They're also looking at the anti-angiogenics. So we talked about that low-grade inflammatory process, that neoangiogenesis, nerve and vascular ingrowth into the synovium. So those
Mm.
drugs would target that inflammatory process, which if you can get that early enough, then
Yeah.
might stop it tipping into that fibrotic
Which
phase.
hinges also, all these things hinge on that early identification, though, eh?
Exactly,
Seems
early
to be, eh?
identification. And some of the immune modulators as well. So they're also looking at immune drugs because
Mm.
it does seem that you get the low grade inflammation that triggers an immune response. So you get a massive macrophagic reaction.
Mm.
And it
Mm.
seems to be that macrophages are the things that modulate that fibrotic process. So they're saying if you can get in and target that macrophagic or that immune response, again, perhaps you will somehow limit that kind of the fibrotic developments and capsular thickening that come after that. So
Mm.
again, all of these are very embryonic, preclinical
Yes.
animal studies at best. As you've said, the difficulty is because we're looking at the angiogenesis, you need to get that in very early. So you need to be able to recognize it early, which at the moment we
Mm.
can't really. It's very
No.
difficult to do that. The immune modulators and the antifibrotics, again, they're not without risk. And I think
Mm.
one of the problems is if you look at frozen shoulder, which is aside from the pain and disability, eventually it's a relatively benign condition with very low risk. And then
Yeah.
you're looking at putting these fairly heavy duty drugs into people to try and reduce pain and
Yeah.
disability in the short term. It's a bit of a difficult scenario to balance there. So
Mm.
I'm not sure how quickly we'll see progress in that area. But yeah, targeting that pathologic process, I think, is an exciting area to watch.
Yeah, yeah, that's really interesting, isn't it? And I think what's really key is through all this process is for clinicians to come back to the pathoetiology that you talked about first. Do you know
Yeah.
that's the key thing here, really, and then address that in those different stages and both in terms of the assessment and the treatment, how they would shape that. Because a lot of these patients do present for physiotherapy, don't they? As a, they would present first to see you. So
They
I
do.
think
Yeah. And
patients
I mean,
should.
guidelines all say physiotherapy for
Yeah.
frozen shoulder. It's like, well, what are we doing and what stage? And I think the pathology really should guide the treatment
Yes.
every step of the way. But at the same time, we've got a patient with an experience who has pain and disability, and we need to be able to manage that as well. So I think, like all of your speakers have highlighted, it is very much a multifactorial. I think we can't only treat the pathology without
Mm.
the person attached to it
Yeah,
because then we're
completely.
doing people a disservice, but we've got to
Yes.
be able to assess what factors we need to target if it's
Yes.
psychosocial or pain processing or autonomic or any of those
Yeah.
factors. We have to have the tools to be able to assess those. But likewise, we can't only do that and ignore the pathology
No.
because, as Fabrizio really nicely pointed out, we know patients want pain relief and range of motion. And if we can't give them that or some
Yes.
solutions or explanations around that, they're going to go somewhere else. So
Yeah.
we need to be doing both, I think, treat the pathology, but also the person.
Yeah, exactly. Do you have any closing remarks for clinicians in this space? What do you think's most important, other than both the pathology and the person? Maybe that's the biggest take home, do you think?
Yeah, I think that probably is for me. And I think what I've learned from listening to your speakers is we just need to widen probably our assessment scope and just understand
Yeah.
that there are phenotypes within frozen shoulder, not only in pain presentation, some of it's inflammatory and nociceptive, but it might be centrally sensitized or neuropathic in nature. But then
Mm,
there are also a myriad of other psychosocial factors that might also influence their experience. So I think it's just being a bit more broad and managing it as a multi-system disease, if you
yeah.
like, rather
Yeah.
than just a biologic problem.
Yeah. That's wonderful, Ange. Thanks very much for your time again.
My,
Great to
ab-
connect with you as always.
my absolute pleasure, Margie.
And thanks again to Flawless Motion for supporting this episode. So, if you want to know more about the shoulder braces or other clinician resources, then head to flawlessmotion.com or flawlessmotion.co.uk for more information. Thanks for listening. I hope you enjoyed the podcast and found some clinically useful tips for your patients in clinic. Please subscribe to the podcast and follow me on social media to keep across the latest releases of the podcast. Don't forget, if you need a shoulder brace for your patients, then check out our shoulder braces at flawlessmotion.com. And if you want to know more about assessment and treatment of rehabilitation of your patients, then check out the online shoulder courses at margieolds.com. Otherwise, take care, enjoy, and see you next time. Please remember that this podcast is for educational purposes for clinicians only and does not constitute medical advice. Please consult with a qualified health professional or contact me to book an appointment for individual assessment and treatment. Cheers.